All right. Thanks again, Bree, and thank you for the invitation to present my research work today as a part of the Focus Aphasia speaker series. For those of you who don't know me, my name is Manaswita Dutta, and I am a researcher and a speech language pathologist. And I very recently completed my PhD from Indiana University, Bloomington. And today I'm going to be talking about my dissertation research work, which looked at evaluating the relationship between executive functioning, discourse, and life participation in people with aphasia. And I also wanted to let you know that I'm also one of the co-founders and members of this excellent working group called Focus Aphasia. And just a small little plug here, if you're interested to know more about our working group, I've listed our website over here. And I also wanted to make a note of this paper that recently got published in CCC-SLP. And again, if you want to know more about our working group, how it started and what our goals are, this would be a great paper to read. And again, if you want to follow us on Twitter, we do have a Focus Aphasia Twitter account. And if you just want to stay updated with all the events and news, this is our Twitter handle. All right, so without further ado, let me get started. Okay. As most of us know, aphasia refers to the impaired ability to understand or produce language, which is most often caused as a result of a left hemisphere brain injury. So a number of language modalities can be affected, including speaking, listening, reading, or writing. And we now know that non-linguistic cognitive deficits are also common in people with aphasia. So they may have problems with attention, memory, and executive functioning. So for my dissertation work, I specifically focused on executive functioning in aphasia. As a lot of us know, executive functioning refers to a set of higher level cognitive functions that are required to complete novel goal-directed tasks. Now, impairments in executive functioning have been commonly documented in people with aphasia, and we can see a myriad of different problems in this population. So they may have problems with working memory, inhibition, cognitive flexibility, or even skills like reasoning, planning, organization, or self-awareness. Now, these impairments in executive functioning are also associated with specific language deficits in people with aphasia, such as auditory comprehension of words and sentences and word retrieval. These executive functioning deficits can further restrict a person's functional communication abilities, rehabilitation outcomes, and potentially their overall quality of life. Now, if you look at the aphasia literature, there are a number of studies that have examined executive functioning in the aphasia population, but very few studies have comprehensively evaluated the nature of these deficits in people with aphasia, representing a range of different language profiles. So the majority of the studies that have already been published have looked at only a limited number of these skills using either singular measures, composite test scores, or just brief screening tools. So we know that executive functioning is quite a multidimensional construct. And so the presence and extent of impairments of people with aphasia on a wide range of these skills is not yet fully known. It also remains unclear whether people with aphasia demonstrate domain-specific or domain-general executive functioning problems. By this, I mean we're not entirely certain whether these individuals present a more global executive functioning problem or are they specific to their language impairment. Now, few studies have directly addressed this issue, but the findings have been quite mixed. So for instance, Baldo and colleagues in 2005 and 2015 reported that reasoning and problem-solving problems amongst people with aphasia were closely tied to their language impairments that could not be explained by a cognitive deficit. Later on, Dr. Laura Murray in 2017 conducted a study where she compared the executive functioning performances of people with aphasia to those who had a right hemisphere brain damage and a group of healthy controls. And the results of this study showed that people with aphasia demonstrated a more domain-general executive functioning difficulty. So overall, there is a need to assess the nature and breadth of these difficulties, and we also need to evaluate how these difficulties may be impacting their functional communication and quality of life. The next aspect that I looked at was spoken discourse in aphasia. And again, a lot of us will be aware with the extensive literature that's out there, and these studies have shown that discourse deficits are quite commonly reported in people with aphasia. And in general, in the acquired brain injury population, we do see that such deficits can have a negative impact on their social participation and quality of life. When it comes to discourse analysis, we can look at the microlinguistic structure or the macrolinguistic structure. So by microlinguistic structure, I'm referring to the lexical syntactic structure of discourse, versus macrolinguistic structure looks at the overall quality of discourse. So again, most of the aphasia studies that have looked at discourse quality in people with aphasia have primarily focused on the microlinguistic aspect, with very few of them examining the macrolinguistic structure of discourse. So some of the common discourse deficits that we might see in people with aphasia may include word retrieval problems, reduced grammatical complexity, more frequent grammatical errors, and differences in word class usage. The few studies that have examined macrolinguistic structure of discourse in people with aphasia have shown that these individuals might show impaired organization, omission of relevant information. They may sometimes provide inaccurate details and also demonstrate reduced coherence and cohesion of their discourse. Now, typically in the aphasia research literature, the microlinguistic and macrolinguistic levels of discourse have been studied rather separately. So it is important to look at the connection between these two levels, and we also need to see how the impairments at each of these levels interact and how that might be affecting the overall quality of discourse. Now, very recently, studies have started to look at this, and the term they use for it is multi-level discourse analysis approach. Some of you might be familiar with this term. One such study was conducted by Andrita and colleagues in 2012, who found that frequent word retrieval problems and incomplete sentence productions produced by people with anomic aphasia was negatively impacting the coherence of their narrative. So the implementation of this approach has been relatively recent. As a result, only a restricted number of relationships have been studied so far. Moving on, the link between language impairments and functional communication abilities in people with aphasia is not as straightforward as we might think. So for instance, some people with aphasia may fail to use language effectively in a complex communication situation despite demonstrating minimal to no language impairments on a standardized aphasia test, for instance. Now, this may be related to the contribution of cognitive factors to spoken discourse ability. And previous studies have shown that cognitive skills such as attention, memory, and executive functioning may influence spoken discourse production. And when we think about it, when we're using language in a more natural communicative context, it can be quite cognitively demanding. So you would first have to activate the information from the knowledge stores and then organize and plan your output and then produce it in a coherent and contextually appropriate manner so the listener can make sense of it. So understandably, it not only requires an intact language system, but this process also draws from a wide range of executive functioning skills. Now, this relationship between executive functioning and discourse has been more frequently studied in the TBI and healthy aging populations, and studies have shown that micro and macrolinguistic discourse deficits are often associated with poor executive functioning performance. Now, the role of executive functioning in conversational success has been previously explored in people with aphasia, but although to a limited extent. So for instance, these studies have not used robust statistical procedures, or they may have relied on proxy measures to look at communication success. The last aspect that I was really interested in looking at was life participation and psychosocial outcomes of people with aphasia. So we know that executive functioning and discourse impairments can significantly hinder social and vocational participation and negatively impact quality of life in people with acquired brain injury. Studies that have focused specifically on the stroke population have shown that deficits in executive functioning skills such as planning, problem solving, and even behavioral regulation can have a significant negative impact on their employment and independent living outcomes. Now, when you take a closer look at the participants included in these studies, you'll find that individuals who've had language impairments are often excluded from such studies. And now we know that a number of studies have started to look at quality of life in people with aphasia. However, amongst the ones that are published, none of them yet have accounted for the role of executive functioning and discourse skills in aphasia-related quality of life. So in summary, there are a couple of research gaps that still exist. So for instance, for the first one, the integrity of executive functioning across a wide range of skills in varying types and severities of aphasia has not been fully studied. Second, it has yet to be established whether executive functioning deficits in people with aphasia are domain general or specific to their language impairment. Third, despite the fact that people with aphasia commonly present with executive functioning and spoken discourse problems, the relationship between these two is not fully understood. And fourth, and most importantly, the impact of such cognitive linguistic difficulties on aphasia-related quality of life has yet to receive empirical attention. So that brings me to my specific study. We had 4 specific aims in this project. So not only did we want to comprehensively examine and determine the integrity of executive functioning in individuals with varying types and severities of aphasia, but we also wanted to ascertain the quality of spoken discourse productions in this population. In addition, we also aimed to determine life participation and psychosocial outcomes of persons with aphasia. And finally, and our main aim of the study was to establish the relationship between these different variables and how that relates to life participation outcomes of people with aphasia. Okay. Moving on to the methods, in this table, you can see the sample characteristics of the participants who were included in our study. So we had 2 groups of participants. We had 22 people in the aphasia group and 24 healthy controls. All the participants in the aphasia group had a left hemisphere brain injury, and all of them were in the chronic stages of recovery, by which I mean at least 6 months post-onset of brain injury. And they were assessed as having aphasia either by the Western Aphasia Battery evaluation or by their clinician's judgment. In the healthy control group, all participants were determined to have normal cognitive functioning as per the Montreal Cognitive Assessment, and they reported a negative history of any neurological or developmental language problems. We did not find any significant group differences between both groups in terms of age or education, but we did find that the aphasia group scored significantly higher on the depression screener compared to the healthy controls, just indicating greater depressive symptoms. All the participants who were included in the study were native English speakers aged between 25 to 85 years of age, with no history of or active substance abuse or any severe psychiatric illness. And all of these participants passed their inclusionary vision and hearing screening. Okay. In the aphasia group, we included a number of different etiologies, but the predominant cause was stroke. In terms of severity, too, we had people with mild, moderate, and severe aphasia. In terms of aphasia type, on the right-hand side, you can see the most common type of aphasia was anomic aphasia, followed by Broca's, conduction, and then we had 1 person with transcortical motor aphasia. We also screened for the presence of apraxia using the apraxia battery for adults and found that 10 people with aphasia demonstrated mild to severe apraxia of speech. So all the people who were interested in taking part in our research study first completed a pre-screening process, and once they passed that, they completed a series of inclusionary assessments. All of the testing took place at university clinics. Testing for 1 person with aphasia took place in their home. On average, it took all participants between 2 to 4 hours to complete all of the testing, and adequate breaks were given in between. Okay. So once all the participants were determined to be eligible to participate in the remainder of the study, they then completed an extensive executive functioning assessment battery. So in this slide right here, I know it's a very busy slide, but in the table on the left-hand side, you can see the names of the tests that we used. And on the right-hand side, you can see the specific executive functioning skills that were examined. So we were interested in looking at both verbal and non-verbal executive functioning task performance. By verbal, I'm referring to the tasks that might require some significant language processing, versus non-verbal tasks are the ones that might require no to minimal language processing. So the ones that are highlighted in red are the verbal executive functioning measures, and the ones that are not highlighted in any color are the non-verbal executive functioning tasks. And so the order of administration was randomized across participants. Next, all participants completed a narrative task. So in this study, we used the Bear and the Fly story, which is a relatively novel story. And as you can see, it's a wordless picture book. So the participants were asked to take a look at these pictures, and then we took the book back and they were asked to then narrate the story. In addition to that, people in the aphasia group completed the assessment of living with aphasia, and their caregivers completed the Sydney Psychosocial Reintegration Scale. So both of these assessments were included in the life participation and psychosocial assessment. Moving on to data analysis, raw and standard scores were calculated for each of the standardized measures that we used. And in addition to that, we also performed some qualitative analysis on some of the executive functioning measures to dig deeper into the executive functioning aspect and to examine planning, strategy use, and the errors that were made. We were interested in looking at both within and between group differences. So these group differences were examined using descriptive statistics and appropriate statistical tests, depending on the normality distribution of the data. And finally, to examine the relationship between executive functioning, discourse, and quality of life outcomes, we used correlations and multiple regression analyses. All of the multiple comparisons were corrected for using the false discovery rate corrections. All of the narrative samples were transcribed verbatim and segmented into utterances, and then they were coded using the chat format and then entered into the CLAN software program for subsequent analysis. Now, for those who are not familiar with chat and CLAN, they're common tools used for language analysis and very frequently used in aphasia research. All of the narrative samples were analyzed in terms of microlinguistic and macrolinguistic aspects. So most of the microlinguistic analysis was done by the CLAN software program, and the macrolinguistic elements were scored by hand. We also checked for reliability of the transcriptions and the scoring procedures, and our results indicated good to excellent intra as well as inter-rater reliability. Okay, so here is a snapshot of all the microlinguistic measures that we used. We definitely used a few more, but just in general, the different elements that we were interested in looking at was, in terms of the microlinguistic elements, were productivity, word class usage, lexical retrieval, and grammatical organization of the narrative. And here are all the macrolinguistic measures that we used. So we not only looked at local and global coherence, but then used this rubric on the right-hand side to look at main concept production, discourse organization, as well as efficient language use. And I'm happy to go over any of these measures after the talk, but just due to time, I'm going over this very briefly. Okay. So moving on to the results, I'm going to be going over the results based on the specific aims. So the first aim was to determine the executive functioning skills of people with aphasia. As a reminder, we used a number of different executive function tests, but again, generally, the main finding was that people in the aphasia group performed significantly poorer compared to the healthy controls on most of the measures that we used and included in the executive functioning battery. And what we found was that in addition to compromised accuracy, some of the tasks, for some of the tasks, the people with aphasia took significantly longer to complete those tasks compared to healthy controls. Okay. As I mentioned during the data analysis, in addition to the quantitative variables, we also did some qualitative analysis to look at how exactly did the participants complete some of the executive functioning tasks. And we did this qualitative analysis for the verbal and non-verbal fluency tasks. The verbal fluency tasks entailed some semantic fluency tasks and then some phonemic fluency tasks. So we were interested in looking at two types of strategy use, which was clustering and switching. Clustering basically refers to subgrouping items into smaller categories. And once you've exhausted a subcategory, then you switch to another subcategory. That way you're coming up with more items for the verbal fluency task. So in these two graphs, what we can see is that the aphasia group, which is highlighted in blue, use these strategies less frequently and less efficiently compared to the control group, which is highlighted in green. Similarly, for the non-verbal fluency task, which was a design fluency task, and in this task, we had the participants come up with as many unique designs by joining these 5 dots that you can see more clearly on the right-hand side, and they had to do that in 1 minute. And interestingly here, we did not find any significant differences in terms of the strategies that were used to complete this task, even though the aphasia group produced fewer designs compared to the control group. The only significant difference we found between groups in terms of the qualitative variables was the design complexity measure. So I'm looking at the third comparison right here, where we found that people in the aphasia group produced fewer complex designs compared to the control group. As a part of the qualitative analysis, we also looked at the frequency of errors and the types of errors that were made for the verbal and non-verbal fluency tasks. So we generally did not find any significant group differences in terms of the errors, but the only difference we found was for, again, the third comparison here, where interestingly, we found that the healthy controls produced more repetition errors during the verbal fluency task compared to the aphasia group. And this pattern has been previously observed in healthy aging adults and just reflects the lack of the ability to control or monitor their own performances when the task is a timed task or when they're under pressure, they tend to produce more errors. Interestingly, here again, for the design fluency, which is the non-verbal fluency task, we did not find significant group differences in terms of the errors that were made between both groups. Next, we wanted to determine how the people with aphasia performed the verbal versus non-verbal executive functioning tasks. So to look at this, what we did is we created a verbal composite score by averaging all the z-scores of the verbal tasks, and did the similar thing by creating a non-verbal composite score by averaging all the z-scores of the non-verbal executive function tasks. And so let me direct your attention to the graph on the right-hand side. A z-score of 0 would mean that person performed at average. A z-score below 0 would mean poor performance. Above 0 would mean better performance. Again, blue refers to the aphasia group and green is showing the control group. And what we see here is that the aphasia group performed poorly on both verbal and non-verbal tasks, but with greater difficulty on the verbal measures. And this makes sense because these measures require a greater language demand. So of course, people with aphasia are at a disadvantage while completing these tasks. We also wanted to take a look at, if there was any effect of aphasia severity or type on executive functioning performance. So to look at aphasia severity, we split the aphasia group into a high and low language group using a median split. And when we compared these two subgroups, we really did not find a consistent effect of aphasia severity on executive functioning performance. The only two tasks where they differed was one task that looked at analogical reasoning and the other was a verbal fluency task. So what we found that the high language group scored significantly better on these two tasks compared to the low language group. To look at aphasia type, we again split the aphasia group into a fluent and non-fluent group using the fluency classification system of the Western Aphasia Battery. And when we compared these two subgroups, we did not find any significant group differences in the executive functioning performance. So in general, overall, the main takeaway is that people with aphasia presented with problems in both verbal and nonverbal executive functioning measures, which lends support to the view that they may be presenting problems, they may be presenting with domain general executive functioning deficits that are not necessarily specific to their language impairments. The other key finding was that not all people with aphasia demonstrated executive functioning problems, and that we saw considerable variability in performances amongst people in the aphasia group itself. These deficits were also not necessarily related to their aphasia type and severity, and the level of difficulty was quite disproportionate across tasks. Okay, moving on to the second specific aim, which was the spoken discourse, and we wanted to comprehensively evaluate spoken discourse outcomes in these individuals with aphasia. First, I'm going to be talking about the microlinguistic analysis results. In terms of productivity, what we found is that the aphasia group took longer to complete these narrative tasks, produced fewer words, fewer correct information units, shorter utterances, and slower speech rate. In terms of word class usage, the aphasia group produced a smaller proportion of nouns in open class words compared to a greater proportion of closed class words. We also looked at lexical diversity using the moving average type token ratio measure, which is the MATTR, and this can be done through CLAN. And when we compared both the groups, we found that the aphasia group demonstrated low lexical diversity compared to the healthy controls. In terms of the lexical retrieval aspect, as expected, we found that the aphasia group produced more word retrieval problems, more grammatical errors, their sentences were less grammatically complete, and they also demonstrated greater instances of empty speech in their narratives compared to control. The macro-linguistic analysis demonstrated that the narrative productions of people with aphasia were less coherent, characterized by fewer main concepts, reduced organization, and less efficient language use. Similar to what we did in the executive functioning analysis, we wanted to take a look at if there was any effect of aphasia severity or type on narrative performance. The only significant correlation we found was that of a positive association between the Western Aphasia Battery aphasia quotient scores and the proportion of nouns produced in the narratives, which meant that people who had milder aphasia were producing a greater proportion of nouns in their narratives. Again, when we took a look at the aphasia types, when we compared fluent and non-fluent aphasia types in terms of their narrative performance, we did not find any significant group difference. So this could relate to the validity of the fluency classification system that's used as a part of the Western Aphasia Battery. And because sometimes it does not match with the clinical presentation of fluency in actual patients. As a part of the discourse analysis, we were also interested in looking at the interrelationship between the microlinguistic and macrolinguistic narrative variables. So for both groups, we found that productivity measures like the total number of words produced or the mean length of utterance was significantly positively correlated with the overall macrolinguistic scores. We also found that difficulty with word retrieval during the narrative task were associated with greater problems with maintaining coherence of discourse. Particularly in people with aphasia, we found that reduced productivity, increased word retrieval problems were associated with fewer main concepts, reduced organization of discourse, and greater global coherence errors. So we do see a connection and an interaction between the micro and macrolinguistic levels. And this again these findings show that problems at the microlinguistic level, which is lexical retrieval or even productivity, might have a negative impact and on the overall connectedness of speech and the meaningfulness of the narratives that are being produced by people with aphasia. Okay, moving on to the third specific aim, which was to examine the life participation and psychosocial outcomes of people with aphasia. As a reminder, we used two assessments. The people with aphasia themselves completed the assessment of living with aphasia, and their caregivers completed the Sydney Psychosocial Reintegration Scale. In the second column here, you can see these are the maximum scores possible for each of the domains that we assessed. And in the third column here, we can see the means of the aphasia group. And when you take a closer look at these values, you see that they achieved low scores on a number of these life participation and psychosocial domains, indicating that aphasia was significantly impacting their quality of life. Next, we also wanted to take a look at whether there were any demographic or injury-related factors that might, have an effect on their quality of life outcomes. And what we found was that age was positively associated with a number of these life participation domains, which indicated that older persons with aphasia adapted better to living with this condition compared to younger adults. Younger adults had to live longer with this disability, and aphasia had a more debilitating impact on their daily lives, their personal relationships, and even their employment. The next factor was aphasia severity. So what we found was that the Western Aphasia Battery aphasia quotient scores were positively correlated with a number of these life participation and psychosocial domains, which indicated that people who had milder aphasia were reporting better life participation outcomes, using those psychosocial assessments. But when we took a closer look at these individual patient scores, we found that at least 1/3 of the ratings were disproportionate to the participants' aphasia severity, which, for example, a person who had mild aphasia was reporting more problems when he went out of the house and interacted with strangers or unknown people, for instance. So this is in line with some other studies that have shown that aphasia severity, as assessed by standardized language measures, may not always be a good indicator of aphasia-related life participation outcomes. Finally, moving on to the main aim of the study, which was to examine and establish the relationship between executive functioning, discourse, and quality of life outcomes of people with aphasia. So to look at these relationships, what we did is we ran correlations, and then as a second step, we did multiple regression analyses. So what I'm presenting to you here on this slide, as well as the next couple of slides, are the findings from the multiple regression analyses. And the ones that are highlighted, the colored boxes, are the outcome variables, and the unhighlighted or uncolored boxes are the predictor variables. So when we just looked at, so here first I'm going to be talking about the relationship between executive function and discourse. When we just took a look at the microlinguistic variables, we found that verbal fluency and non-verbal fluency scores were significantly predicting these two microlinguistic variables, which are also related to productivity. So these two executive functioning tasks examine skills such as initiation, planning, organization, and even self-monitoring. So what these findings are telling us that problems with these skills may impact the narrative productivity of people with aphasia. As has been previously seen in the TBI population as well as healthy aging populations, we found that a number of executive functioning skills were significantly predicting performance at the macrolinguistic narrative level. So in our case, we found that a number of verbal fluency variables were significantly predicting performance on these macrolinguistic measures, which means that poor performance on the verbal fluency tasks were significantly associated with greater problems in terms of coherence, production of fewer main concepts, reduced organization of discourse, and also compromised quality of discourse at the macrolinguistic level. So what these findings tell us are that skills such as initiation, planning, sequencing, and even cognitive flexibility may be playing a role in maintaining a coherent and organized narrative output. So difficulties in any of these skills may impact the narrative production. Apart from verbal fluency, we also found that tasks that examined verbal analogical reasoning and attentional switching were significantly correlated with a number of these narrative measures. This is important to note because these skills have been previously shown to impact communication abilities in people with brain injury. Interestingly, we did not find any correlations amongst the macrolinguistic narrative and non-verbal executive functioning variables. So these findings indicate that people with aphasia are less efficient in employing the executive functioning skills in tasks that are heavily mediated by language. So what is happening is that during a narrative task, their executive functioning impairments are becoming more pronounced and evident. The lack of correlations could also mean that some of the executive function tasks that we use may not have tapped into the skills involved in narrative production. The lack of correlations could also mean that the narrative task that we used, which was a story retell task, may not have been challenging enough to employ these executive functioning skills that we assess. So overall, what we find is that in addition to their language impairments, problems with executive functioning abilities of persons with aphasia may be negatively contributing to their compromised narrative performances. So because of their executive functioning deficits, they have problems or difficulties with efficiently applying strategies, generating main ideas to convey the story in a coherent and organized manner. And they also have difficulties with monitoring and correcting their own responses. So our findings are generally in line with previous studies that have shown that executive functioning may be related to functional communicative success in the aphasia population. Okay, so the next relationship that I am going to be talking about is that of executive functioning and life participation. Here, what we found is that a number of executive functioning skills were predicting significant variance in these life participation outcomes, as we had assessed using the assessment of living with aphasia, as well as the Sydney psychosocial reintegration scale. So here what we found is that not only were the verbal, but non-verbal executive functioning measures were accounting for significant variance in these life participation domains that we looked at. And not only that, but we also found that quantitative as well as the qualitative variables were significantly accounting for some variance in these psychosocial and life participation domains. So what we find is that low life participation scores of people with aphasia are associated with executive functioning difficulties in skills such as planning, cognitive flexibility, and self-monitoring. These executive functioning skills may be similarly involved in several daily activities that we do on a regular basis and can interfere with social interactions and successful life participation of people with aphasia. This relationship particularly has not been looked at previously. So from our findings, we can see that poor executive functioning can contribute to reduced aphasia-related quality of life. The last relationship that I'm going to be talking about is that of discourse and life participation outcomes. When we only took a look at the microlinguistic, which is the lexical syntactic variables, the narrative variables, we found that speech rate and mean length of utterance, again, both of them look at productivity, were significantly predicting these life participation domain scores of people with aphasia. As has been previously observed in the TBI population, we also found that a number of macrolinguistic narrative variables, such as main concepts, local coherence, as well as discourse organization, were accounting for significant variance in these different life participation and psychosocial domains. So we find that narrative performance was significantly associated with life participation and functional outcomes. We found that narrative abilities were more sensitive and better predictors of aphasia-related quality of life than just discrete language impairments as we assess using standardized language measures. So definitely, narrative tasks were more ecologically valid as they were representative of real-world communication situations. Okay, so to summarize the findings from my study, we found a significant relationship amongst executive functioning, discourse, and life participation of outcomes of people with aphasia. Our findings indicate that executive functioning and spoken discourse abilities appear to be important factors in functional communication and quality of life outcomes in these individuals. Our findings also offer new insights regarding assessment and treatment planning for people with aphasia. So just to discuss some clinical implications from this research, there's definitely a need to address executive functioning and discourse more routinely in aphasia assessment and intervention, because we need to improve their functional communication and life participation outcomes for this population. Through our comprehensive assessment, we also identified testing measures that are less time-consuming but provide us with more details that might be helpful in our assessment and treatment planning. And finally, our findings definitely highlight the importance of using patient-reported measures that are more informative, because it gives us information from the perspectives of the people with aphasia themselves. And as clinicians, it help us identify barriers and evaluate activity and participation-related outcomes in people with aphasia. Okay, moving on to the last bit, which is study limitations and future directions. We did have a good enough sample size, but we definitely could have benefited from greater statistical power. We also had limited diversity in our aphasia group. So for instance, most of them were highly educated, or we also excluded people with severe depression, for instance. So in the future, studies should definitely include a more diverse clinical sample and look at what other factors might be impacting aphasia-related quality of life. The narrative measures that we used did not include other communication modalities, but when I was collecting data, I realized that a lot of these individuals with aphasia were relying on other communication modes like gesturing or writing to communicate more information about the story. So, but we could not accommodate for these using the metrics that we used for the narrative analysis. So future work should definitely include these other modes of expression in discourse analysis. And finally, in this study, we only focused on a story retell task, but this relationship between executive functioning and spoken discourse should be further examined using other discourse genres like a picture description or something less structured like a conversational task. So that brings me to the end of my presentation today. These are my references, and a huge thank you to my mentors and collaborators, Dr. Laura Murray and Dr. Bria Stark. And again, much appreciation for all of my research participants, all of the research assistants at the Neuro Research Lab, and faculty members at Butler University for helping me get all my participants. Thank you. Any questions?
Thanks, Manaswita. That was awesome. Sorry, I turned my video off. My bandwidth was going a little bit crazy. Let's go ahead and open it for questions. So anyone want to unmute and ask Manaswita any questions?
Hi, Manaswita.
Hi.
That was a really nice job. I enjoyed your study. When you were administering these tests, especially the kind of the verbal cognitive tests, did you get a sense that the individuals with aphasia were actually doing the task and their errors were reflected their cognitive function as opposed to the linguistic aspects of the directions and the task?
Yeah, that's a great question. And I didn't mention this during my presentation, but we did accommodate for some of these. So for instance, when we used the test of everyday attention, we used two subtasks where they had the option of either verbally responding or they could just, point to a number. So if you're familiar with the elevator counting with distraction, they have to respond with a number at the end. And so we gave them that option. So those kind of accommodations helped me differentiate whether it was really language or whether it was a cognitive kind of problem.
Great.
Yeah.
And I'll follow up with, I should have a couple of questions.
Sure.
And you identified at the end, one of the issues would be potentially being underpowered for other kind of analyses, but
right.
Could you, if you were to collect more data doing this very type of analysis, collect more data on more individuals, do you think you could do some kind of a cluster analysis to look at whether there are particular patient profiles that might, that could potentially identify patient profiles where individuals will respond differently to treatment or respond differently to certain types of strategy development?
Absolutely, and that's an excellent question. I keep thinking about this even when I was writing up my dissertation. As I mentioned earlier in my presentation, I definitely saw there was a lot of variability in performance. So given the sample size that I had, I did the analysis that I could, but definitely if I can collect more individuals, data, then that would be something I would be very interested in, because ultimately we want to know is which people with aphasia will respond better to treatment. So my hypothesis is people who have better cognitive flexibility, for instance, might respond better to treatment and might use these strategies. So definitely a cluster analysis would be such a fantastic idea to look at and see, just to differentiate these profiles, because right now what I'm seeing is a lot of variation, and we shouldn't be. This is the disadvantage of a group level analysis where we're clustering everything together and we're saying that they are performing poorer compared to controls. But when you look at the individual scores, that's not the case. So definitely a larger sample size and a different kind of analysis to see their individual strengths and weaknesses is definitely a next good step. Thank you.
Thanks.
Any other questions?
And sorry, not to monopolize, but I've got to, just a comment to that. I know one of your mentors was Laura Murray, and I have to say, as you were going through your talk and you were mentioning that narrative performance was a better predictor of quality of life than performance on impairment-based measures. I know that Laura had several papers from probably like 90s, 2000s, where I feel like she's one of the few people who actually would survey her participants at the end of a treatment study and see if they or their family members noticed or observed any change in functional performance. And she would report that these incredible data of people improving on, say, a reading task or a naming task, but then at the end, the family and the participant not necessarily recognizing any functional change in performance.
Yes, that's a very important thing you talked about. And actually, I experienced that firsthand during data collection. When I would administer the Western aphasia battery, for instance, I thought that only gave me part of the picture. When I actually engaged with them using the assessment of living with aphasia, which is a fantastic assessment. I know it takes time. It takes about 45 minutes, but that gave me so much more constructive feedback. If I were practicing in a clinic, that information would be such a good supplement to the standardized testing that we do. So definitely that's an important aspect to look at.
Great. I think we've got a few people having to go, but Manaswita is always available offline as well. So I will just go ahead and give a clap on my end since it's awkward.
Thank you.
But it's been a pleasure. I'm super excited to see what you do in the future with this. I know you and I are still working on a lot of things coming out about this. But look for this soon on YouTube. And thanks again for doing this, Manaswita.
Thank you all for joining in.
See you all soon. Bye.
Bye.
Thank you.